Today we will talk about diagnostic coronary angiography. My name is João Silva Marques. I'm an interventional cardiologist in Lisbon. So the simulators are a very good opportunity for the fellows to learn, and most of all it's a very good opportunity for them to practice without having the problem of harming patients. So for diagnostic coronary angiography, what do we need? First of all, we need an arterial access, and we have placed in here a 6 French sheet in the radial artery, and we are going to perform coronary angiography through the radial artery. So first of all, we need to get a diagnostic catheter and a guide wire. The guide wire is very important because we don't want to traumatize the arteries, and the guide wire is always going in front of the catheter, and the catheter goes over the wire. So I will show you how we do that. We always have to flush the catheters, so we don't want any air inside the arteries, or it will signify an embolic stroke, and that's something we don't want, neither in the coronary arteries nor in the peripheral system. So we have the flushed catheter. This is a JL diagnostic catheter, a 5 French catheter, and I'm going to put the J wire inside the catheter. So when I see the tip of the J wire coming out of the catheter, I'll pull it back inside the catheter, and then I use the catheter inside the sheath to go through the valve, the hemostatic valve, and when I go there without further advancing the catheter, I will advance the guide wire. So the guide wire always in front of the catheter. So this is a standard J wire, but sometimes we have to do the catheterization with hydrophilic wires. For me, it's not the standard approach because the hydrophilic wires have more tendency to go through small arterioles and can perforate or do dissections, and so for you that are beginning to do coronary angiography, it's not a very good wire to start with. So we advance the catheter over the wire. When we reach the aortic arch, we can check with the X-ray. Usually the wire has a tendency to go to the right coronary sinus when we go through the radial route, and one of the differences is because of the approach we have here. Most of the times we have to use smaller catheters than when we go femoral. So when we reach the aortic route, we can take the wire back. It is very important once again to take the air out of the system, because this is a pressurized system. There should be no air inside, but for making sure, it's always a good practice to get a syringe and take some blood out of the system. In this case, our simulated blood. Then we flush the catheter and connect it to the diagnostic catheter. The placement inside the artery should be taken just after we flush it with contrast, but sometimes it's not possible and the catheter engages the left main. But it's one more tip to don't get air inside the left main and on the left coronary artery. So this is a very important trick again when we are manipulating catheters. This hand that is closer to the sheath should be used to advance and take back the catheter, and this one it's for rotation, clockwise rotation or anti-clockwise rotation. We will flush the system with contrast. Okay, we have contrast. Then we pull the catheter a little bit outside and it engages the left main ostium. So this is pretty much the basics. So we have engaged the left main. We are now going to perform diagnostic coronary angiography. So we have a power injector in place, so we will check. We will do a projection that is the LAO cranial, and then we perform coronary angiography in this projection. So for the LAD we can do the right AO cranial view. It will give us a better view of the mid and distal part of the LAD. So we will inject contrast again. A spider view. It is very useful for the left main and also for the proximal LAD and proximal circumflex. So we will inject contrast. Okay, so here we will see better the ostium of the LAD and also the bifurcation of the LAD lesion with the first diagonal. Let's see. Okay. So what I didn't tell you before is that we can change the anatomies that we see here, because we 3D printed them and we make them flexible, so we can dilate it and then we can perform interventions. But we can digitally manipulate the arteries so that we can create stenosis in type A stenosis, complex stenosis, like some of the ones that we are seeing in this video. So we'll see better the left circumflex and the distal LAD in this projection. Okay, and so we had 4 projections for the left coronary artery. Indeed, we had 5 this time because we had to get a better look of lesions that we identified, but minimum we need to assess an artery are 3 projections, because we don't want to miss a lesion when it is eccentric. So it is a very important message, is that we cannot be satisfied with just one incidence for one artery. So in the left coronary arteries we need at least 3 projections. A very important message now is that when we want to change the catheter, we have to take it out of the ostium of the left main, because once again we don't want to get the J-wire inside the left main. That could traumatize the left main and create a dissection. That's something we really don't want. So we have to take it back. It's better if we use the X-ray, or in this case the simulated X-ray. So we take it out of the left main, and then it is safe to use the J-wire inside, so we can reach the aorta and safely take the catheter out without losing the access that we had to the aorta. In this case it was easy to get access to the aorta, but sometimes it's difficult. So it's inside the ventricle, we have to take it out. But sometimes it's difficult, as I was saying, so we don't want to lose the access to the ascending aorta. And so we exchange the catheter over the wire. It's a conventional J wire, as I told you. Another important message is that we should always check the pressure inside the artery, because there may be an ostial lesion, or maybe our catheter it's very close to the wall of the coronary artery, and if we inject and we don't have pressure, we can create a dissection, or we can create an arrhythmia like a ventricular fibrillation. So that's something we don't want to do, and that is very important that we have to think about that when we are performing coronary angiography. And now we will see what we can find in the right coronary artery. So we have the wire in place. So when we perform right coronary artery diagnosis, once again we have the J wire in the aortic root. We advance the JR4 catheter over the wire. So once again the wire has a tendency to go to the right coronary sinus, but we don't want the catheter to engage automatically, so we should place the catheter tip facing the left side. So like this. We take the wire back. We can let it bleed a little bit, but it's once again more safe if we take some blood out. And then we flush the system that we are going to connect and connect it. Again, we are out of the coronary artery. We are in the right coronary sinus. And we are going to flush the catheter with contrast. So we have to make sure that contrast is arriving at the catheter, so no air is inside. And for the right coronary artery catheterization, we have to manipulate the catheter a little bit more than on the left. So we have to first take the catheter against the right coronary sinus, so it bends a little bit, facing the left side, and then we have to take it slowly out and rotating it clockwise. So we shouldn't rotate it, we should not be too energetic when rotating, so we have to take it back. Now it engaged the right coronary artery. So we are ready to perform coronary angiography on the right side. So once again we have to get some projections. One is not enough. So we will take a conventional LAO projection. Okay, so here we have the lesion in the proximal part of the non-dominant right coronary artery, and then we can see it in the LAO cranial view. That is more important to see the mid segment and the distal segment. Okay, and now we will do RAO view, that it's important to see the posterior descending artery, that in this case it's not coming from the right coronary artery but from the circumflex, because it's a left dominant system. Okay, so we had a good look of the coronary arteries. Never forget, going back to the LAO projection. So once again, we have to make sure that we don't get any air or any material inside the artery. So the first thing to do is take the catheter out of the artery. Now we can put the J wire in. And as we have finished the diagnostic coronary angiography, we can take the catheter and the wire out. So everything is concluded for diagnostic coronary angiography. but very important is to review the images after we take them. So the type A lesion on the right coronary artery will be approached first for a simple PCI procedure. And we'll go through step by step as we did this time, and then we can go to more complex disease like we have in the left coronary artery. So once again, thank you for watching, and I hope to see you again. I hope you will be here again to watch another video of Cath Lab in the Basement. Bye.